Good afternoon, everyone, and thank you for joining us for an encore presentation with Dr. Charlene Fell. Her presentation is, I've been diagnosed with pulmonary fibrosis, now what? Dr. Fell is the chair of the Canadian Pulmonary Fibrosis Foundation Medical Advisory Council. She's the founding chair of the Canadian Thoracic Society Clinical Assembly on Interstitial Lung Disease. She's the director of the University of Calgary Interstitial Lung Disease Program. She's the site chief, Respirology South Health Campus. Dr. Charlene Fell.
Thank you, Sharon. Thank you for that kind introduction. First, I just want to check in, Sharon, and just make sure that everyone can hear me okay on the microphone. Hopefully everyone can hear me. So thanks very much for the kind introduction. I'm really happy to come back in, give encore presentation of this talk that I did earlier in the month on September the 8th. I had some feedback from Sharon that folks wanted to spend some time talking a little bit about more on what they can do to help themselves. So we'll spend some time on that. And then I also heard through Sharon that folks wanted to have the whole topic of what is pulmonary fibrosis reviewed again. I understand that maybe there's some family members on the call today that were not available on September the 8th, so I'm happy to go through that again. Sharon, can you just remind everyone how questions are going to work? Because I would like to be able to answer questions as we go along.
Yes, so what will happen is if people have questions that they would like to have clarified, I will step in when Dr. Fell finishes the presentation and just say, Dr. Fell, could you explain or expand on that? Or otherwise, I'll wait to the very end.
Great, and so what I'll do is my talk is in a few sections here, and before I move on from one section to another, I'll just check in with you, Sharon, to make sure that there's no questions.
Absolutely, thank you.
Thank you. All right, so the title of my talk is I've been diagnosed with pulmonary fibrosis, now what? Which I picked this topic because it's really overwhelming to receive this diagnosis, and until you become involved with the pulmonary fibrosis community or perhaps with a clinic like our clinic here in Calgary or the dozen or so clinics across the country, there is not a lot of information out there about pulmonary fibrosis, so I'm hoping to give you some information and just explain what this diagnosis is and how you can help yourself with it, and some things that you can keep in mind when you come back and talk to your medical team. So pulmonary fibrosis starts in many different ways for people. So you may be somebody who was perfectly well until something happened, like a cough or a cold. And we hear this story all the time in the clinic where people are well and then they got a cold and then they had a cough and the cough just wouldn't go away. And it was after seeing their doctor about this cough that wouldn't go away that they found out, surprisingly, that they had pulmonary fibrosis. Another scenario is that some people just progressively get more and more short of breath. Things that they used to be able to do, like bound up from the basement stairs to the main floor, became more and more difficult. And then finally, they brought this to the attention of their family doctor, and they were eventually diagnosed with pulmonary fibrosis. And some patients spend quite a long time working with their family doctor, maybe a respirologist or other specialists, trying all the different puffers and trying to figure out what is the problem with their breathing. And eventually, after a long period of time, they are diagnosed with pulmonary fibrosis. It's quite a different pathway for each individual to arrive at a diagnosis with pulmonary fibrosis. And we know from our medical scientific literature, and then also from the report from the Pulmonary Fibrosis Foundation released earlier this month, that patients on average, it takes about 2 years on average to finally figure out that what is going on is pulmonary fibrosis and not asthma or COPD or some other problem. So whatever your journey is, you have wound up at this point where you were given a diagnosis of pulmonary fibrosis. And we find that once people arrive at this point where they know what the diagnosis is, there are so many questions that they have about what to do here. And that's the focus of the talk today. So what we're going to spend the next 45 minutes or so on is to talk a little bit about what is pulmonary fibrosis. It's fairly technical from where I sit with my doctor hat on. So I want to try to explain some of the technical things that we consider when we're looking at a patient with pulmonary fibrosis. We're going to talk a little bit about what you can expect with the diagnosis of pulmonary fibrosis, with a lot of different caveats or exceptions thrown in there, because there are a lot of different diseases in this group of disorders, and each one is a little bit different. And then at the end, we're going to talk about things that you can do to help manage the pulmonary fibrosis, things that you can do on your own, and things that you can do with the assistance of your medical team. So what is pulmonary fibrosis? So pulmonary fibrosis is a kind of the plain English term, or the common term that we have used to describe what really is a large group of diseases which cause inflammation and scarring of the lungs. The technical term that physicians will use, and some of you may hear this in your clinics with your doctors, is interstitial lung disease, or ILD. So that is the formal technical term, interstitial lung diseases. Pulmonary fibrosis is more the common language term that we use. The interstitium is the part of the lung that holds all of the structures together. And so let's just see if I can get my mouse working here. So I'm just showing you a cartoon of the lungs here. And if we blow up a section of the lung, we can see that there's a small airway, and at the end of the airway is an air sac called an alveolus. Many air sacs are called alveoli. The oxygen that you breathe in the air goes into the air sac, and then it crosses through the interstitium, which is like supporting structures of the lung, or the scaffolding of the lung, or the framing of the lung for those of you who are builders. And there are blood vessels that are around the alveolus, around the scaffolding that the oxygen diffuses into to deliver oxygen to your body. And then carbon dioxide, which is our waste gas that we breathe out, diffuses out of the blood into the alveolus, and then we breathe it out again. The interstitium is kind of this supporting structure, and the oxygen has to cross the interstitium in order to get into the bloodstream. When we have, as illustrated in this circle on the left-hand side here, the interstitium is the supporting structure that the gases have to cross through. When we have interstitial lung disease or pulmonary fibrosis, there's usually inflammation and scarring of this interstitium, or of this membrane, and it becomes thickened. And it impairs the diffusion or the flow of oxygen into the body. When the interstitial lung disease gets very, very severe, the carbon dioxide has trouble getting out, but usually for most people, it's the oxygen coming into the body where we run into most of the problems. So that's kind of the background of what the interstitium is and what interstitial lung disease is. It's a group of diseases that affect this part of the lung, and then pulmonary fibrosis is the common English term that we use for interstitial lung diseases. So pulmonary fibrosis or interstitial lung diseases, I mentioned before, it describes a very large group of diseases, or a family of diseases that all have effects on this part of the lung. There's over 200 different kinds, and we like to torture the medical trainees, like the residents and the medical students. We like to torture them in the clinic by having them rattle them off. We group them into categories based on the underlying cause of the problem. And some of you may recognize this because when we meet you for the first time in the pulmonary fibrosis clinic, we ask you about 300 different questions. And what we're trying to figure out with our questions is what has caused the pulmonary fibrosis. So was it something occupational, meaning was it something that you were exposed to in the workplace environment? So asbestos, for example, coal miner's lung, so it's coal and silica from mining activities. There's a disease called farmer's lung, which is based on grain dust out here in the prairies, but in other parts of the country, it may be mold, moldy seed, moldy grain, etc. There's autoimmune interstitial lung disease, and this group of diseases cause pulmonary fibrosis because there is an underlying condition in the body, like rheumatoid arthritis, or scleroderma, or another condition, where the condition attacks the joints, for example, but also attacks the lungs. So these are autoimmune diseases that cause pulmonary fibrosis. So your respirologist or your doctor may ask you about joint pain and swelling and skin changes and rashes and all kinds of funny questions that have nothing to do with the lungs. We're trying to figure out if there's an underlying disease in the body that is causing the pulmonary fibrosis. Another cause of pulmonary fibrosis is things that we do to patients. We call it iatrogenic, and these would include side effects of drugs or side effects of radiation therapy for certain kinds of cancers. So for example, there's a kind of chemotherapy called bleomycin that has the potential to cause pulmonary fibrosis. Amiodarone, which is a drug used to treat some heart conditions, has the potential to cause pulmonary fibrosis, and so on. Before you get all concerned and start going through your medication list, I just want to be clear that these medications, in some people where we think they have underlying predisposition or susceptibility to getting pulmonary fibrosis, that these drugs can contribute to pulmonary fibrosis in some patients. There's many, many patients who take these drugs who don't have any problems with their lungs. But we do know that in some individuals, there's a list of drugs longer than this and radiation that can cause scarring in the lung. So that's another group of causes of pulmonary fibrosis in this big family of pulmonary fibrosis disorders. And then finally, after we go through all of our questions and do all of our blood work and other tests, sometimes we cannot identify a cause of the pulmonary fibrosis. And in that case, we would say that the pulmonary fibrosis is idiopathic. So I like to joke in clinic that idiopathic is kind of like we're too idiotic to know what the cause of the pulmonary fibrosis is. Obviously, there's a cause. It's just that in our scientific research, we haven't quite figured it out what it is. And so the most common form of an idiopathic form of interstitial lung disease is a specific disease called idiopathic pulmonary fibrosis, or IPF. This is a very specific form of pulmonary fibrosis among the 199 other kinds of pulmonary fibrosis. There's quite a lot of research being done in IPF, which is why if you Google pulmonary fibrosis or if you search for interstitial lung disease on your other search engine, most of what you're going to get back is all about idiopathic pulmonary fibrosis, but that might not be what you have. You might have one of the other forms of pulmonary fibrosis. And I imagine on this call today, there's a bunch of you who have IPF and there's a bunch of you who have something else. So just to keep that in mind, pulmonary fibrosis is not all IPF. And those of you who have something different than IPF, it's important to understand that because your disease may behave differently than IPF does. Another analogy I like to use to describe pulmonary fibrosis in the clinic is to think about pulmonary fibrosis just like you would think about dogs. So I think we all know what a dog is. There are many, many different kinds of dogs, and dogs all have very common characteristics. They have forelegs, they have ears, they have a nose and a snout, they have a waggy tail, but as you can see, each particular dog is a little bit different from the other one. And when we're trying to figure out what pulmonary fibrosis a particular patient has in clinic, we're trying to look at these very particular clues when we ask questions of patients or look at the blood work or look at the CT scan to try to figure out if there are characteristics that make it look more like IPF, or are there characteristics to make it look more like, say, scleroderma, interstitial lung disease. It's the same way that you would look at a dog and you would say, well, it's got this kind of coloring and this size and this shape of ears, and so it's going to be a German Shepherd. And a dog with a different kind of coloring and a different kind of coat and a different kind of ear is going to be a poodle, for example. So hopefully you can understand, using this analogy of dogs, that there are different kinds of pulmonary fibrosis, and although they have very similar features, they're all a little bit different and unique from each other. So for example, some of the common features that pulmonary fibrosis patients all have are cough and shortness of breath. And in some people, the cough comes first, and some people, the shortness of breath comes first. Doesn't really matter. The cough can be dry, which means that you don't bring up anything when you cough, or the cough can produce a sputum. Doesn't really matter. Those two things don't really help us figure out what kind of pulmonary fibrosis you have, because nearly everyone with pulmonary fibrosis will have cough and shortness of breath at some point. Most people with pulmonary fibrosis will become fatigued, particularly as the disease gets worse, and this is usually related to shortness of breath on exertion. People in clinic are asking us all the time about finger clubbing, so I've put a picture in there about clubbing of the fingers. That's when the fingernail looks a little bit different at the end of the finger. It looks like a little drumstick at the end. This is very non-specific. Many people with pulmonary fibrosis will get clubbing, but certainly not everyone does. And then the other thing to keep in mind is that there are other conditions that can cause clubbing, like heart disease or liver disease. And so clubbing doesn't always mean that there's scarring in the lung. If you have clubbing and you've never been diagnosed with a lung problem before, it would be worthwhile to see your family doctor about that and to get yourself checked out. But clubbing does not always equal pulmonary fibrosis. It's common, but not universal. Another symptom that a lot of people with pulmonary fibrosis have, particularly as it gets on to its later stages, is weight loss. And again, it doesn't help us differentiate between the different kinds of pulmonary fibrosis. It's just one of these common symptoms. One of the key things that does help us figure out the different kinds of pulmonary fibrosis is the high resolution CT scan of the chest. So what I have shown here is 6 different CT scans from 6 different patients that I have seen over the years. And my patients where I'm showing the CT scans have all given me their permission to show their films, as long as we don't identify them. And you don't even need to be a radiologist or a physician to be able to look at these scans and to say, wow, they all look a little bit different, don't they? And so just to, I'm just going to go to the middle one on the top row here and let you know that the dark area that I'm pointing to here, which is on the left-hand side of your screen, that's actually the right lung. And the dark area on the right-hand side is the left lung. We do it backwards just to make everything confusing for people. And then in the middle of the CT scan is the heart and the structures in the middle of the chest that have the airways and the big blood vessels. And so where I'm showing you in the CT scans here, we're at different points along the chest. So in this particular one in the top middle, we're seeing through the heart. And this one on the top left-hand side, we're seeing where the airway divides to right and left. And if we go down to the picture that's at the bottom right, we're seeing way down at the bottom of the heart and the top of the liver here. But that's not what I want to draw your attention to. What I want to draw your attention to is if you look at the lung itself, which is the dark area inside the body, that the pattern of abnormalities here is very different from scan to scan. So this person has these white lines around the outside of the lung. That's called reticulation. That means some scarring. There's a few little, if you're on a phone, you won't be able to see this, but if you're on a nice big TV screen or big computer screen, you can see that there's some little circles here, white circles with black in the middle. Those are called honeycomb cysts. So this person probably has UIP or IPF. This person has all kinds of kind of grayish, smudgy looking, fuzzy little dots all over the lung. This is a different form of interstitial lung disease called DIP. It's very different. This person over here on the right also has some of these subpleural reticular changes and some cysts. They look a little bit different. If we go down here to the bottom left, the changes look very different. Some reticulation and then some smudgy dots that are in the lung. This one looks quite different. There's big white blobby things. This is a kind of interstitial lung disease called cryptogenic organizing pneumonia, or COP. And then down here on the bottom right is a lot of honeycombing. You can see that the lines look very lacy. All the white stuff, the white lines, is scar, and there's no normal lung down here. So this is advanced fibrosis. A number of different kinds of pulmonary fibrosis can eventually look like that. The point that I'm trying to make here by showing you all these scans is to show you that even though people with pulmonary fibrosis have common symptoms of shortness of breath, cough, fatigue, weight loss, clubbing, that inside them, when we look at the CT scans, the pulmonary fibrosis can look quite different. And it's the characteristics of the CT scans, as well as the story that we hear from patients, that helps the doctors decide, is this IPF? Is this asbestos? Is this farmer's lung, bird fancier's lung, rheumatoid arthritis, related to a chemotherapy, or what specific kind of pulmonary fibrosis is this? So we put all the information together and we try to figure it out. So what we do in the clinic, like I was just alluding to, is we take your story, we do our physical exam, which is when we listen to your heart and lungs, poke your belly, look at your hands, all those things. We look at the CT scan of the chest. We do the breathing test or the pulmonary function test. We do some blood work looking for clues for underlying conditions like rheumatoid arthritis, scleroderma, and a long list. Sometimes we need to do a lung biopsy, but oftentimes we don't. We put all that information together and we try to figure out what is the specific kind of pulmonary fibrosis that somebody has. So this is how a lung specialist or a respirologist or pulmonologist thinks about pulmonary fibrosis or interstitial lung disease. So when we put all that information together, we try to apply that to a classification scheme. So interstitial lung disease is the same as pulmonary fibrosis, as I mentioned earlier. We have a large group of diseases where we know what the cause is, so related to an autoimmune disorder, related to things that you could be exposed to either in your workplace or in your hobbies, things that you can be exposed to usually in your workplace, sometimes in hobbies that are inorganic like asbestos or silica, and then iatrogenic, or things that we do to patients like give them medication or radiation therapy. There's the idiopathic interstitial pneumonias, which is the ones where we cannot find an underlying cause, and of those, idiopathic pulmonary fibrosis or IPF is the most common, but you can see that there's a short, there's a short list of other ones as well. And then there's another disease called sarcoid, which we don't typically see in the pulmonary fibrosis clinics because usually it behaves quite differently. And then there's some very rare disorders that we see. I want to point out that there's this box down here floating around all by itself called unclassifiable interstitial lung disease. And a few of you on the call might have this, or your family member might have this. I certainly have a few of these folks in my clinic. And what unclassifiable interstitial lung disease means that despite all of our best effort, we are unable to get all of our information together and decide what is the cause of the pulmonary fibrosis. And we assign this diagnosis to patients who have a CT scan that does not look like the CT scan for IPF, because IPF has a very distinct looking CT scan. So if your CT scan looks like something different, but we're unable to assign a diagnosis, our next step would be to do a lung biopsy. And if we can't do a lung biopsy, or sometimes if we do a lung biopsy, we still can't figure it out, then we call it unclassifiable interstitial lung disease. It means we're stuck. Most of the time though, probably about 90–95% of the time, we are able to assign a diagnosis to people who present with pulmonary fibrosis, and we go through our questions, our blood work, etc., and we're able to assign a category of pulmonary fibrosis, and that is your diagnosis. So one of the things that you can do for yourself to help you through this journey with pulmonary fibrosis is to write down your specific diagnosis. So your doctor may say that you have ILD, or he or she may say you have pulmonary fibrosis. You want to know, doc, which one is it? And write it down so that you know your specific kind of pulmonary fibrosis. Really important. So Sharon, I'm just going to pause there before I go on to the next section and see if we have any questions so far on what is pulmonary fibrosis.
So far, you've actually explained most of the differences. So people were saying that because of the differences in pulmonary fibrosis, is there a different drug treatment for them?
Yeah, that's a really good question. We're not going to talk about drugs in this specific talk, but I do think that a talk was given earlier on in the month that goes through different treatments for pulmonary fibrosis. So Sharon will have that information up on the CPFF webpage for you. In general, if you have IPF, then the drug treatments are towards an antifibrotic medication. So the two drugs available in Canada are nintedanib, which is marketed as a drug called Ofev, and the other drug is called pirfenidone, which is marketed as a drug called Esbriet. That's for IPF. If you have any other kind of pulmonary fibrosis, then the treatment really is tailored towards whether or not your pulmonary fibrosis has more inflammation. And if you have more inflammation in your particular disease, your doctor is going to talk to you about maybe using an anti-inflammatory drug like prednisone or mycophenolate mofetil, which is marketed as Cellcept in Canada, or there's generic forms, or maybe a drug called rituximab, which is marketed as Rituxan, or azathioprine, which is marketed as Imuran. There's a few different anti-inflammatory drugs. Some of these other diseases will benefit by being treated with nintedanib or Ofev. We use that for IPF, and we know that it is effective in some of these other diseases that have scarring as their main feature. The only problem is that in Canada right now, we don't have a way to get the Ofev paid for if you have a disease that is different than IPF. That's a big challenge that we have moving forward as a pulmonary fibrosis community, is to convince the provinces to include Ofev on their formularies for these other diseases.
Yes, so Charlene, I just want to add that the Canadian Pulmonary Fibrosis Foundation actually submitted a CADIF form in order to ask them to make that approval. And then we would then have everyone help us to move forward from every province to say, could we have that drug cover for those people who are not termed as IPF? So I just want to add that portion.
Yeah, and then there's a bunch of us from the physician side who are working with the regulatory bodies to try to get our voices heard from our end. So there's a bunch of us from both the CPFF end and the physician end to try to get this drug available to patients.
Okay. I've got one more question for you, Dr. Fell. Someone asked you if they have autoimmune disease like scleroderma or rheumatoid arthritis and it runs in their family, does that mean that they are also should be thinking about PF?
Oh, that's a great question. We do not have a firm answer for that question, but what I can tell you is that, first of all, We know that these autoimmune diseases can run in families. They don't always run in families, but they can run in families. And then we also know that pulmonary fibrosis can be common in some of these autoimmune diseases. So scleroderma and rheumatoid arthritis, for example, it's more common for people to have scarring in the lung with these diseases than maybe some of the other kinds of autoimmune disease. So the rheumatologists, those are the doctors who take care of folks with rheumatoid arthritis and scleroderma. They have become very, very interested in screening patients up front for the presence of interstitial lung disease, or, you know, in other words, they are actively looking for scarring of the lungs in their patients with these diseases. And so as part of your regular care, your rheumatologist will be doing x-rays and breathing tests to check on your lungs to see if you are developing any changes that might point to pulmonary fibrosis if you have one of these diseases. So we don't really go screening for pulmonary fibrosis in family members of people who have, say, just rheumatoid arthritis. What we would do is we would be looking for rheumatoid arthritis in family members. And if a family member has rheumatoid arthritis, then we would start looking for the pulmonary fibrosis. It's a little bit different for people who have a condition where the pulmonary fibrosis is known to run in the family. So this has nothing to do with autoimmune disease now, but for those group of people, we think there's probably 20 to 30% of people with pulmonary fibrosis will have it in their family. And in those cases, most of us who run a pulmonary fibrosis clinic across the country will look for pulmonary fibrosis in your first degree family members. So for example, I have a few patients here who are in their 60s and 70s, and I follow them for pulmonary fibrosis, and I get a request to maybe screen their children, and we will have a look at the children. So far, I haven't found pulmonary fibrosis in any of the kids of the people I take care of, but we will go back and look every 3 years or 5 years because there is a higher risk. There are some genetic testing kits that are available for research use. We don't have a commercial kit available in Canada right now, and that's some work that in Alberta we're trying to do to get the kit available to us to use to screen family members for pulmonary fibrosis. We just don't have that ability to do that yet. So
Dr. Fell, this person wants to know if their grandmother or their mother and themselves have, scleroderma or rheumatoid arthritis, should they be worried? Should they go get checked out?
Should they, if they have scleroderma, should they get checked out for pulmonary fibrosis?
Mm-hmm.
Yeah, and the place where you would start that is you would start by asking your rheumatologist or your family doctor just to listen to your lungs, maybe do an x-ray, maybe do a breathing test.
Okay.
Yeah.
Okay, thank you.
Thanks. Any other questions before I move on to our next section?
Oh, that's it.
Okay, all right, folks, we're going to move on to the next section, which is what can you expect when you have pulmonary fibrosis? So this is a difficult part of the talk because pulmonary fibrosis is a really tough diagnosis. And those of you who are living with pulmonary fibrosis know this. This is a really tough disease to live with. What I'm showing you on the screen here is a series of x-rays from my very first patient with pulmonary fibrosis. This fellow happened to have idiopathic pulmonary fibrosis. And I met him when I was a fellow back in 2004. And we start on the left-hand side of the screen. This is his x-ray. His right lung is over here where I'm pointing. The left lung is on the other side over here. The lungs should be nice and dark. And what you can maybe appreciate is that there is a lacy network of lines overlying the lung. That's the scarring of the lung. And over time, as we move through time to the middle panel and then over to the far right panel, the lacy scarring gets to be worse and worse over time. So This is certainly true for people who have idiopathic pulmonary fibrosis, or IPF. It is also true for patients with several other kinds of pulmonary fibrosis that you can expect that it will get worse over time. So it's hard to have a conversation with a mixed group of audience members like yourselves about what to expect with pulmonary fibrosis, because the disease behaves differently in different people, and then each different kind of pulmonary fibrosis is a little bit different than the rest. We have most of our information about IPF, and so I'm going to talk most about IPF and talk about some of the other ones as we go through. So what you can expect overall is that pulmonary fibrosis, regardless of what specific kind you have, is a chronic condition. And an important thing to understand is that pulmonary fibrosis, the fibrosis is scarring. Scarring in the lung is just like scarring anywhere else in your body. Once you have a scar on your skin, in your lung, what have you, the scar does not go away. And that is part of what makes this a chronic condition, because once the scar has formed in the lung, that scar is not going away. That little piece of lung with the scar in it is damaged. And in many forms of pulmonary fibrosis, more of the lung is going to become scarred over time. So this is a chronic disease. It's not going away. Many other conditions are also chronic and not going away, like high blood pressure, diabetes, etc. So this is one of these chronic diseases. The other thing that I think is really common and what you can expect, especially after you've been diagnosed, and then as you move through the different phases of the disease, is a big emotional roller coaster. So you might feel angry that you got pulmonary fibrosis, and who wouldn't? You might be very stressed or anxious about the diagnosis. You may be depressed. Why did this happen to me? You may feel all alone because it is a rare condition. So you can expect that this emotional roller coaster will come, and some days it will hit you like a 18-wheeler truck, and some days it won't be so bad, but it is a tough diagnosis to deal with. You will get symptoms from your pulmonary fibrosis, particularly as time goes on and the disease gets worse. You will start to have more symptoms. So that cough, shortness of breath, and fatigue that I talked about early on are the symptoms that you get from pulmonary fibrosis. The disease is expected to get worse over time, and so you can expect that your symptoms will get worse over time. It may be hard to discuss your pulmonary fibrosis with your friends and family, and I'm hopeful that the seminar today and all the seminars throughout Pulmonary Fibrosis Awareness Month in September will help you have these conversations with your friends and family. It's hard to discuss it because it's really technical, all these words that we're using, the 200 different kinds, it's hard to explain it. If you have IPF, there's lots of information about IPF on the internet, but there's hardly any information about the other kinds of pulmonary fibrosis, and it makes it really hard to talk about it. And then the other thing that's really hard, especially for people who are in the more early stage of their disease and they don't have oxygen yet, is that you don't really look sick until you get up and you try to run up the stairs and then you lose your breath. And so it's hard for people to recognize that you might have something going on in the lungs because you don't look different. You're not wearing a cast. And of course, all of that changes when you start oxygen because things look different after that. So these are difficult conversations to have for all of those reasons.
Excuse me, Dr. Fell, sort of interrupt you. Someone wanted to know from one of the support groups is, why do some people go for a long time without having exasperation and going down, while others succumb to this disease within 2 years?
I think I have a slide that will address that in a couple of minutes.
Okay.
And if I don't answer that question directly, maybe could you remind me again? But to whoever asked that question, I think I have a slide that explains that.
Okay, thank you.
Thanks. So other things that you can expect is that over time, because the scarring gets worse in the lung and because your symptoms get worse, it's going to be harder for you to do things. So you might have to stop working. You might need oxygen to help you breathe, and you may need help at home, first with heavy household chores like mowing the lawn and shoveling the snow and vacuuming. And then some people do need help with more day-to-day basic things like getting dressed or taking a shower. Okay, I think this slide will address that question that you just brought forward, Sharon, for whoever was on the line. So what I'm trying to show you in this graph is what you can expect with pulmonary fibrosis represented in a graphic form. So the medical term for this is called the natural history of IPF, which just means what is the course of this disease, or how does it play out? So what we're showing you along the horizontal line here, along the bottom line here, is a time scale measured in years. And what I'm showing you on the vertical graph here is survival or lung function. There's a number of different ways that we can talk about this, but it's basically a representation of how well you're doing, where if you're at the top of the line here, you're doing really, really well. And if you're at the bottom of the line here, you are not doing well. And the bottom of the line here represents death. So we know that there's a period of time, and sometimes it is months to years, kind of off to the left-hand side, where the scarring is slowly building up in the lungs, but you don't know yet because you don't have your cough or you don't have your shortness of breath. Some people get picked up early because they go for an x-ray for another reason. They fell and they hurt their shoulder, they get an x-ray, the scarring is found in the lungs. Or they go and they get their gallbladder taken out, they get a CT scan, the scarring is found in the lungs. So some people are picked up early in this window of time before they get symptoms. But for most people, the symptoms are developing for a period of time, and then they start to get their cough and shortness of breath. And then there's a period of time, maybe a year, maybe 2 years, where it takes us a period of time to figure out what is it. Is it IPF? Is it rheumatoid, interstitial lung disease? What is it? That's what the diagnosis arrow here means. And I put it here at this 2-year mark because on average it takes about 2 years to figure that out. You'll notice that there's a few different lines here kind of cascading down. There's, and this is the course of the disease. So the person was asking, you know, why do some people do really poorly, where from the time they get their diagnosis to the time they die is sometimes as short as 6 to 9 months. And some people do much better, where the time to diagnosis to the time to when they die is sometimes 8, 10, 12 years. And we certainly see both extremes in our clinic. The short answer is we don't actually know why some people have a more rapid course and why some people have a longer course. It is a hot area of discussion right now. There is a very aggressive form of pulmonary fibrosis called Birt-Hogg-Dubé, where people just get sick and they pass away within months. It's a very specific diagnosis, but there are people with IPF who survive for a shorter period of time, like maybe 1 or 2 years. And there are people with IPF who survive for a longer period of time. And we do not know why, to answer your question. What we do know is that if something happens to your lung when you already have scarring in your lung, it can make things worse. So we call these acute exacerbations, or you could call it a flare of your lung disease. If you know somebody with COPD, or chronic obstructive pulmonary disease, that's a different kind of lung disease. It has nothing to do with pulmonary fibrosis, but these folks will have a flare of COPD, or a period of time where their breathing will get worse. So we call that acute exacerbations, which is what I'm trying to show in the blue arrows here. And these can be caused by, you know, getting a virus, a viral pneumonia, getting a pneumonia, having a blood clot, having a heart attack, or fluid on the lungs. So if there's an insult to the lungs, it can stir things up in the lungs and make the scarring worse. And then for the most part, people will have a step down in their lung function, and they won't get back up to where they were before that event happened. And when you have one of these things, so if you have pulmonary fibrosis and then you're hospitalized for pneumonia, chances are that your lung function will come down a little bit. It may come up again, but probably not to where you were before. And then things march on until maybe you get the next insult to the lungs. So one of the things that you can do for yourself, and I'll talk about this in a few minutes, is you can work really, really hard, like you are doing right now during the COVID pandemic. You can work really, really hard to make sure that you don't get an infection, whether it's a viral pneumonia like influenza or COVID or a bacterial pneumonia, those kinds of things. We'll talk about that again. And then the other thing that can change the course of the disease is if you have two different problems in the lung at the same time. So here in the red line, I've shown IPF and emphysema, and some of you might have that or might have family members with that. If you have two problems in the lung at the same time, like IPF and emphysema or IPF and pulmonary hypertension, then things tend to progress faster because the lung has got two hits against it. Sharon, I see you popping on.
Yes. So there's two questions. Yes. So you mentioned COVID-19. So someone wanted to know, they know someone who survived the COVID, and they're wondering, will this person, have pulmonary fibrosis as a result of that? There's just been so many mixed messages, so they're wondering, do you know if they should be concerned?
That's a really great question. So I think, Sharon, do we have a whole talk on COVID during this month that is going to get posted afterwards?
No.
No. Okay. So we could spend a whole hour just talking about COVID and pulmonary fibrosis, but in a nutshell, what we know about COVID is that it is a respiratory virus, which means that it enters the body through the respiratory tract and sometimes the eyes. So the nose, the mouth, sometimes the eyes. It will cause a viral pneumonia, so infection in the lung. But in some people, and we don't know how to predict who those some people might be, but in some people, the infection is not just limited to the lungs. They can have a whole cascade of inflammation all throughout their body. Some people after COVID will wind up with scarring in the lung, that is for certain, but other people will wind up with heart problems or kidney problems. Some people wind up with chronic fatigue. The virus has really only been around for just over 10 months now, and we are still learning so much about this virus. So we do not yet know who is going to wind up with scarring in the lung or heart problems or kidney problems, for example, but we do know that it's a risk. And so I guess what I would say is that if you know someone who's had COVID, or if you've had COVID and you're having trouble with your breathing still, or if you don't feel quite right still, you need to go back to your family doctor to get, heart, lungs, kidneys checked out, chronic fatigue, all those things checked out, because we know that COVID in some people, not everyone, but in some people can have lifelong effects afterwards.
Okay.
In Calgary, we have a COVID clinic that is running to help take care of folks who have some of these chronic conditions. And I would imagine that in the major university cities across the country, that there are COVID clinics being set up, not to treat people with active COVID, but to treat people and to figure out their problems after they've recovered from the more severe part of the illness. And I hope that answered your question, whoever answered.
Yeah. Thank you, Dr. Fell.
Okay. Was that it, or are there other questions?
Nope, that was it.
Okay, so we were talking about what you can expect with pulmonary fibrosis, and one thing you need to understand is the natural history of the disease. So this is IPF that I've shown you. The natural history of the disease is different if you have asbestosis, or if you have amiodarone, which is a drug, amiodarone toxicity, or if you have radiation, or if you have rheumatoid arthritis, or if you have hypersensitivity pneumonitis. the graph for each of these conditions looks a little bit different. So it's really important to know what you have, and you can get your doctor to explain what the natural history is. We don't know the natural history for all 200 kinds of pulmonary fibrosis, but we do have a pretty good idea for the more common ones. So please ask your doctor about the natural history or what you can expect with this disease. Okay, this is putting the natural history of pulmonary fibrosis into kind of a framework to help you understand in terms of day-to-day terms. So here we are using a really nice infographic from Genentech. So Genentech is the parent, is a company in the US which is owned by Roche. Roche and Genentech are the company that makes pirfenidone or Esbriet for IPF. So just keeping that in mind, I don't think that this graphic is there. This graphic is not here to talk to you about Esbriet. This graphic is here to help you understand the natural history of IPF. And so, for example, Eugene's journey, I think in this infographic, is a really nice illustration of what you can expect over time. So in the beginning, Eugene, who's 65, likes to golf. In the beginning, he has some scarring in his lungs, but he actually does not have any symptoms. He's able to golf and do everything that he wants to do. And let's just say that he can pull his clubs for 18 holes and has no problem, does that a couple times a week. Eventually, the scarring will get worse. Eventually, he will have more shortness of breath and some cough, and he's unable to walk the course, and he's definitely unable to pull his clubs, and he would need to take the cart, for example. He might not be able to rush up a flight of stairs coming from the kitchen up to the bedroom, for example. That would become more uncomfortable. It's around this time that probably he went to see his doctor, and he would eventually get some testing, including blood work and a CT scan, and get a diagnosis of IPF. As the disease gets worse, the breathing becomes worse, the cough becomes worse, and then the physical limitations become more prominent. We're even doing slight things like here, watering the garden, just makes him exhausted. Going up the stairs would be very, very difficult. And it's around this time that we would start thinking about oxygen to help support Eugene's breathing. And you can see in the very far panel on the right that there will come a time that even with the oxygen, as the pulmonary fibrosis gets worse, he will still be short of breath, even walking short distances with the oxygen, such as going down to the end of the driveway to the mailbox. This is a different kind of way of illustrating the natural history of the disease, putting it into some concrete terms that hopefully you can relate to in terms of day-to-day life. So I want to pause there, Sharon, before I get into the next section about what people can do to help manage their pulmonary fibrosis, to see if there's any questions, any other questions at this point.
No, there isn't. Thank you.
Okay, thank you. So the next section, folks, is things that you can do to help manage your pulmonary fibrosis. And I think I tried to put down here maybe the things that I think are the most important to try to highlight those. And we'll go through them, and you can, and guess I would say that the most important things that you can think about are exercise, preventing infection by vaccination, and then education and support, which is what I'm trying to show in the bottom panel here. This is actually, the bottom panel picture is a training session for the leaders of support groups organized by the Pulmonary Fibrosis Foundation. And if anyone is from Calgary on the line, you'll recognize Kirk, our pulmonary fibrosis support group leader, sitting in the plaid shirt in the back row there, getting his training done a few years ago with the Pulmonary Fibrosis Foundation in the US. Okay, so how can you manage your pulmonary fibrosis? So the most important thing, I think, is to learn as much as you can about your particular disease. You want to know your specific diagnosis, like I said a few times before, so very important. Write it down. Make the doctor spell it for you if you need to, but make sure you understand exactly what it is that you have, because that obviously will drive everything about how the disease is going to play out in you, and then how we are going to be giving you advice about it as physicians. You want to understand the natural history of your disease, and we talked about that for IPF. You want to understand the natural history for what it is that you have. And you want to make sure that the information that you are getting is correct and up to date. And I've listed on here a few different websites which provide medically correct information that is also geared towards patients and family members. So not for doctors and nurses, written in plain English. So the Canadian Pulmonary Fibrosis Foundation website, which you all know about because you've made it to this seminar, is an excellent source of information. The Lung Association of Canada, and then your provincial or territorial lung association, also has information on pulmonary fibrosis and the different subtypes. In the US, there is an excellent patient information series of pages at the Mayo Clinic. So the Mayo Clinic is a private healthcare facility in the US, but they have very good documents available to the general public. And then the NHLBI, the National Heart, Lung, and Blood Institute of the US, so www.nhlbi.gov, is a scientific community, but they also have very good patient-facing or patient-geared information on pulmonary fibrosis and a whole multitude of other diseases on those two sites. If you have rheumatoid arthritis or scleroderma, pulmonary hypertension, a few other things, there are other patient-related websites and support groups that will provide information about those specific diseases. They may not have as much information about the pulmonary fibrosis part of the disease. And so if you're looking to learn about pulmonary fibrosis, I would start with the Canadian Pulmonary Fibrosis Foundation website and maybe branch out from there. So, step number one, learn as much as you can about your pulmonary fibrosis. Step number two, you want to build your team. So your team are all the people who are going to support you in your journey. So certainly your family and friends. When we see people in the clinic, we really like it when you bring in a family member or a support person into the clinic. Most of us across the country now have protocols that will allow a family member or a support person to come into the clinic with precautions during COVID. Or if you're having a video conference or a telephone call with your doctor, you could certainly have your support person on the line. And I even learned how to do three-way calling so that we could do that for a few of my patients. We like to have another patient there. They can be a second set of eyes and ears. They can take notes for you. They can ask you questions. Also, you're going to need your team to help you as the pulmonary fibrosis gets worse, to help you with running errands and getting equipment and maybe even helping taking a shower and getting meals and those kinds of things. So build up your team.
Dr. Fell, sorry.
Yeah.
Someone wanted to know, they go with their loved one to their patients' visits, but their loved one gets upset when the doctor asks, how are you feeling? How are you doing? And they say they're fine, but they feel compelled to say, well, no, this happened and that happened. Is that appropriate? Is that okay? Because, you know, they want to support that individual, right?
Yeah, so that's a tricky question. So some family members come to clinic and are really upset to hear about the diagnosis and how things are going or not going well. And some family members like to come, and if the patient says everything is fine, the family member like to says, well, there's this time and there's this time and there's this time. I think all those things are really valuable. So it's really hard in a 10 or a 15-minute appointment with your doctor to kind of sort through some of these dynamics. If you come as a pair, a patient and a support person, and maybe the patient and the support person are not seeing eye to eye, or they're at different levels of understanding about the disease or accepting of the stage of disease. And this is where I think that the support group can really help provide some extra support that we might not be able to do in a 10 or 15-minute visit in the clinic. It's always valuable for us to have a support person there. Some people choose to come on their own, and of course, it's their right, and you're welcome to come by yourself. Plenty of my patients come to see me by themselves. But I guess my point is that this is a chronic disease, and this disease is going to get worse, and you can't do it by yourself. And you're going to need some help down the road with this disease. So the point with my comment is to start building your team, and maybe your support person doesn't come to the first few appointments, but eventually you're going to need somebody to help you actually get to the appointment. So the point is to think about building your team, and hopefully I've answered that question.
Yep, thank you.
Okay. So apart from the support person, the other people on your team are the medical folks. So your family doctor, who should be your quarterback, the respirologist or your lung specialist, your nurse in the clinic, respiratory therapist. Usually they come with the oxygen company, or sometimes they're attached to the clinic. Some people see a dietitian, physiotherapist, rehab or exercise therapist. There's a whole team of people who will be either connected to your family doctor's office or connected to the pulmonary fibrosis clinic, who can help you manage all the little bits and pieces and address specific questions to help you through this journey. The third thing that you can do, really important, is to commit to healthy choices. So for example, you can stop smoking. If you have stopped smoking in the past, you can not start smoking. Don't vape. Don't smoke marijuana. Marijuana is legal now, but I wouldn't smoke it. I would have it in some other form. So don't smoke. You can exercise regularly, and if pulmonary rehabilitation is not available in your community, there's a really nice online program through the CPFF website. I've just taken a screenshot and put it up here for you. This online exercise program was developed by the rehab team at University Health Network in Toronto. It's excellent. They have a sit-down program and a gentle standing up program, which will help get you moving. So important to stay moving with this disease. You need to do all that you can to not get sick. And in the last 6 to 9 months in Canada, we've all learned what we need to do to protect ourselves from the COVID virus. But all of these learnings that we've done with COVID, such as hand washing and social distancing and wearing a mask, they will help for all the viruses. I'm not suggesting that once the pandemic is over that you still need to wear a mask. I'm not suggesting that. During the pandemic, until the medical officer of health says it's safe to stop doing these practices, of course you should do them. But vigilant hand washing is something that we've all learned how to do, and that will help you moving forward to not get sick. Social distancing, or staying away from people who are sick, is a change that many of us have made in our lifestyles in the last 6 to 9 months, and that will help you moving forward not get sick. And then vaccination is so important. So I would recommend that you are vaccinated against the flu, and you need to get your flu vaccine every single year because the virus changes year to year. The flu vaccine is available right after Thanksgiving across Canada. Many places now you can get it in your local pharmacy. You don't have to go into a doctor's office. I would also recommend that you get vaccinated against pneumonia or bacterial pneumonia. There are 2 different pneumonia vaccines that are available in Canada. One is called Pneumovax, one is called Prevnar. They have overlapping effectiveness. You'll have to ask your doctor in your province about if they are covered and or how much they cost. So in Alberta, Pneumovax is covered, but Prevnar is not covered for everyone. So it may be different province to province. Ask your family doctor about that. But I would recommend that you get, at a minimum, Pneumovax. And if you can, I would get both Pneumovax and Prevnar. The other thing that I would consider is to get the shingles vaccine. Shingles very rarely affects the lung, but shingles is nasty and so painful. And if you've had shingles, you will know how terrible it is. I would not wish it on my worst enemy. If you're in a lot of pain from shingles, it is going to be harder to breathe. So why don't we prevent the shingles from happening in you and just prevent that pain, and which is going to make the breathing worse. So I would recommend shingles vaccine if you haven't had that already. Other things to do to help to commit to healthy choices. So maintain a healthy body weight. So being overweight is not good for you. Likewise, being underweight is not good for you. So you want to be in that sweet spot, and your family doctor can help you figure out what is a healthy weight for you and then how to get there. You want to eat a well-balanced diet. Lots of people ask me in clinic, are there special foods or a special diet they should follow? There is not a specific diet for people with pulmonary fibrosis. What I would recommend is that you follow Canada Food Guide and eat the majority of the things that you eat to be fruit and vegetables. If you have other health conditions, diabetes is a good example. You may have to follow a diet that is tailored to your diabetes. So you want to eat a well-balanced diet. You want to be thoughtful about other medical conditions that you have, and a dietitian or your family doctor would be a good resource to make sure that you're on the right track for that. The other thing that I would recommend, point number 4, is that you learn to manage your medications. So when we're dealing with patients with pulmonary fibrosis, we will offer you treatment. The drugs have all these crazy names. They're taken once or twice a day. They all have side effects. And the doctor is going to go through and make sure that the drugs do not interact with your other medications. But it really is important for you to understand, what are your medications? When are you supposed to take them? What is that blue pill for? What is it called? And what are you taking it for? And so your family doctor can help. Your pharmacist can certainly help go through all of your medications. You should know the name, the dose, why you're taking it, when you're taking it, and any side effects. And if you have more than a couple of medications that you're taking, it's really handy to use a dose set, which is the blue and purple thing on there. I have one of those for my pills, makes it really handy, or a blister pack that your pharmacy can fill for you. And then it just makes it so much easier than trying to fumble through all your bottles 2-3 times a day and make sure you get the right things. All right, step number 5. How can you manage your pulmonary fibrosis? You can do exactly what you're doing right now, which is to reach out to your community for support, because you are not alone with this disease. Thousands of people across Canada have different forms of pulmonary fibrosis, and we can all support each other. So you could join a support group locally, either in person or now, because of the pandemic, virtually. You can join an online forum, and there are plenty of them around, and you can talk to other people who've been through what you're facing. And I think that part is really important. I've been taking care of patients with pulmonary fibrosis for just over 15 years now, but I'm not living with this disease, and I don't really know what it's like to be so breathless. And I think it's all very fine and dandy for me to be sitting here with my doctor hat on, giving you this talk, but I think that it is equally important, and maybe in some instances much more valuable, to speak to other people or other family members of other people who've been living with pulmonary fibrosis, and really find out what it's like and what to expect. And then the other thing is that your community of support people through either the CPFF or through online forums or support groups, they have all these tips and tricks for how to make things easier for yourself. So what to do with the oxygen cord and how to manage the oxygen, or different little hacks to make things easier. And so people who have been living with this disease have all kinds of knowledge that I don't have, because I haven't lived with pulmonary fibrosis, and I think it's really valuable to reach out in that way. Number 6, you want to be aware of depression, anxiety, and stress. I mentioned a while ago that this diagnosis is an emotional roller coaster, and a lot of people get very depressed or very anxious and worried about their pulmonary fibrosis. These are perfectly normal and natural reactions to a chronic illness. You want to be aware, though, of when your feelings are starting to interfere with your normal day-to-day activities or responsibilities. So when they start to interfere with your sleep or taking your medication or seeing your doctor even, or even having contact or communication with your friends and family, if your feelings are starting to interfere with that, then it's probably time to get some help. Either see your family doctor for help with depression and anxiety. There are lots of ways to get support for depression and anxiety that doesn't involve medication at all, and your family doctor is the right place to start exploring those issues and helping you through them. All right, step number 7, how can I manage the future with pulmonary fibrosis? This is a really tough topic, this one, number 7. You want to plan for a future where your health is going to decline. We call this advanced care planning, and it involves everything from making a bucket list and getting through your bucket list, to thinking about, can you stay in your home and who's going to take care of you, all the way to how do you want your final days to be? Do you want them to be at home? Do you want to be in a hospice? Do you want to use medical assistance in dying and have some control over death? So a whole lot of topics to talk about, and we could spend a whole hour just on this really important, really difficult topic. So you want to think about if there are things that you want to do, especially if you're early on in your disease, and if you're still well. Are there things that you want to do that maybe you should get done now? Is there someone that you want to see, or a place that you want to travel to? Right now we're just traveling in Canada, but hopefully the COVID pandemic will lift, and maybe you want to do some traveling while you still can. Are you going to be able to live in your home? If you have stairs, how are you going to manage the stairs when it comes to the point where you can't manage stairs? So you're going to move to a different home, or maybe have a stair lift? Do you need to do some renovations? Do you have your affairs in order? Do you have a will, power of attorney, those kinds of things? Who's going to help you with some of the day-to-day errands that become more difficult, like getting groceries or getting out to a doctor's office when you become so breathless that you need help with those things? When the disease is more advanced, do you want to come into hospital for aggressive care if you got sick, or would you want to be given just comfort measures and without aggressive medical care? And again, like I mentioned earlier, how do you want your final days to look? All of these discussions are very, very challenging, and they will kind of evolve over time. And your ideas about what is important to you may change as you move through your chronic pulmonary fibrosis, this chronic disease. It's important to have that team of friends and family that I was talking about earlier to talk about all these things with. They're going to be the team to help you when you are more limited by this disease, and the team who will be supporting you as you make some of these decisions. In Alberta, we call it advanced care planning. I think many of the other provinces have similar names to this kind of discussion. Your family doctor and your respirologist will certainly be able to guide you to resources in your community about working through some of these issues. So, Sharon, are there questions about this? Because my next slide is my wrap-up slide.
So there was another one, somebody wanted to know, is the pneumonia vaccination a one-time only, or is this a yearly thing?
Oh, thank you for asking that question, because I didn't mention it. So the pneumonia vaccine, Pneumovax, is good for 10 years. Prevnar, I believe, is also good for 10 years. At least we haven't started vaccinating anyone, haven't started boosting anyone with Prevnar. So those are good for 10 years when you get them.
Okay, and someone also wanted to know if there was a vaccination for COVID-19, should they go and get one?
I would. So I would actually. a couple things about the COVID vaccine. So they're still in development, and you'll hear on the news that there's clinical trials that are ongoing. The clinical trials are very, very rigorously conducted. You can be certain that when a vaccine is available in Canada, that it is going to be a safe vaccine, because Health Canada has some very strict regulations around vaccines in this country. And so when Health Canada approves a vaccine for public use in Canada, then yes, I would get the vaccine. We do not know what this vaccine is going to look like. And so, for example, some vaccines are we call them live attenuated vaccine, and some vaccines are dead vaccines. So the shingles vaccine is a good example where one brand is a live attenuated vaccine and one brand is a dead vaccine. People with certain medical conditions cannot have a live vaccine, even if it's attenuated, which means that the virus is not supposed to replicate. So some people with certain medical conditions cannot get one of the shingles vaccines. When it comes to the COVID vaccine, we'll have to pay attention to what the vaccine looks like when it is available, and whether or not everyone can have it safely, or if there are some people with medical conditions who couldn't have it. And when the vaccine is being studied by Health Canada, they will certainly make all of that information available to the public. But what I would say is, if the vaccine is safe for you, then I would definitely recommend it, just like I also recommend the flu vaccine, and I also recommend vaccination against pneumonia.
Okay, thank you. Thank you for reassuring the audience about the safety of the COVID vaccination, because several people have said, well, you know, they're developing this so rapidly. How do we know that they adhere to all the high standards that, you know, that usually they are held to when you're creating a vaccination?
Yeah, that's a lot of us in the medical community share that concern. So for example, you might have heard that Russia released a vaccine a couple of weeks ago, and it had only gone through what we call a phase 2 trial and not a phase 3 trial. That would not happen in North America. So we really need to go through our phase 3 trials, which are rigorous testing to make sure the vaccine is safe. We share, the medical community shares your concern that we want to make sure the vaccine is safe.
Okay, great, thank you. Someone else also wanted to ask you, you had talked about how PF might run in families. Is there like a specific test, or do we just ask our children to, you know, go be tested, or how do you determine that?
Oh, thank you. That's such a great question. So let's just talk about pulmonary fibrosis that runs in families. And so the first thing is, what do we consider familial pulmonary fibrosis, or pulmonary fibrosis that runs in families? So the definition that we're using in the research community is, if you have one first-degree relative with pulmonary fibrosis, we call it familial pulmonary fibrosis. So if there is a parent-child or a brother-sister, that would be a first-degree relative. And so if you have pulmonary fibrosis and your brother has pulmonary fibrosis, we would call it familial pulmonary fibrosis. If you have it and your dad had it, we would also call it familial pulmonary fibrosis. And we do, when we bring patients into the clinic to try to figure out what kind of pulmonary fibrosis they have, we do ask a family history to try to figure out if there's any lung diseases in the family. We also ask about those other diseases I talked about, like rheumatoid arthritis and scleroderma, to try to figure that out. So now I want to move on to a different concept, which is, you know, there's 200 different kinds of pulmonary fibrosis, and can they all run in families? So IPF certainly can run in families, and we think about 30% of people with IPF there'll be a family history, but other kinds of pulmonary fibrosis can also run in families. We think what happens is that there's some kind of genetic mutation that puts people in a family at risk of getting pulmonary fibrosis, and then something happens, like they're exposed to grain dust, or they're exposed to metal grinding fluid, or they get a bad pneumonia, and then that triggers pulmonary fibrosis. And in those families, maybe the trigger is different for the different individuals, but they all get pulmonary fibrosis. We do have some research labs in North America that are doing genetic testing. And so for some of us physicians caring for these patients, we will refer patients to these research centers if they're interested in being part of a research study to get their genes tested. But I do not have a genetic test that I can offer patients who come into my clinic. We just don't have a commercial kit available. Just like I could order a blood test to look at your blood counts, I cannot order a blood test to look to see if you might have a genetic mutation that we could identify that would say that, you know, your family members, if they have that mutation, are at risk.
Okay.
It's taking a very long time to explain the concept, but the short answer is that yes, it can run in families. There are some genes that we know when they're mutated can increase the risk of pulmonary fibrosis, but at the present time, we cannot offer genetic testing to patients in the clinic because right now the genetic tests are considered a research tool and are not considered a clinical tool.
Okay.
Hopefully that answers the question.
Yeah. Thank you, Dr. Fell. Our next question is, someone wanted to know, now that they know they have this disease, you know, in what phase should they think about perhaps a lung transplant?
So, if you have pulmonary fibrosis, we would think about transplant in general for people who are under the age of 70 across Canada, and people who are non-smokers, and people who do not have other major medical problems like cancer or severe heart disease or severe liver or kidney disease. And then your weight has to be not too high and not too low. So you have to have a healthy body weight. And so if you are over the age of 70, if you smoke, if you have any other major medical problems, or if you are obese or too underweight, we would not consider a lung transplant. But you could quit smoking or lose some weight or gain some weight to try to change those variables. For everyone else, we generally start talking about lung transplant if we see that the lung function is declining in somebody who would be eligible for a lung transplant, so under the age of 70 without those other medical problems. We sometimes talk about transplant right up front at the very first visit. And sometimes we wait to see if things are changing, because sometimes people come and they've been stable for a number of years. And we don't think that things are going to change for a while. So sometimes we have that transplant conversation a little bit later in our relationship with our patients.
Okay, thank you.
Yeah.
That's all I have for now.
Okay. All right, well, thank you very much, folks. I just want to wrap up with going over a summary of what we talked about over the last little while. So you've been diagnosed with pulmonary fibrosis. There's a lot that you can learn and do, and there's a lot that you can control of, even though this seems like a disease where you don't have very much control at all. So the things that you can do is you can understand pulmonary fibrosis, understand your specific kind of pulmonary fibrosis, and that'll help you know what to expect and to plan for the future. You want to build your team. You want to make healthy choices, and there was a long list of healthy choices that we talked about. You want to learn to manage your medications. You want to get support because this is a rough ride. This is a tough disease. You want to recognize and manage depression and anxiety, knowing that these are normal reactions to a chronic disease that is going to get worse. and you want to start your advanced care planning sooner rather than later. And I think with that, I would like to thank you all very, very much for your attention. I'd like to thank you all for your questions. I'd like to thank Sharon and the CPFF for hosting this event and for putting on such a fabulous Pulmonary Fibrosis Awareness Month for the month of September. Thank you very much.
Thank you, Dr. Fell, for doing this encore presentation. I want to thank her and all the other wonderful respirologist doctors who presented this month, and also to Boehringer Ingelheim Canada and Roche Canada, for without their support, we couldn't have had this platform today for all of you to enjoy. Thank you so much again, Dr. Fell, and thank you everyone for joining us. Have a great day.